welcome, and thank you for joining in on this OCD Intervention Framework webinar. My name's Swan Morgan, and I'm the Senior CBT Therapist in East Sussex. And the webinar is designed to help support initial assessing clinicians can identify OCD as a primary presenting difficulty in initial assessments, and hopefully support placements of those young people onto the most appropriate intervention pathway. So I'll just guide us into the presentation. So essentially what we're going to be covering throughout this presentation is just looking at a brief overview of OCD, what moderate to severe clinical presentation of OCD looks like, some key questions for assessing OCD in your initial assessments, and also understanding the OCD intervention framework. So just a brief overview of OCD. So the DSM-5 definition is the occurrence of unwanted, recurring and intrusive thoughts and or repetitive behaviors or mental acts that are time-consuming and cause significant distress or interfere with daily functioning. The definition of OCD went through some significant changes on transition from DSM-4 to DSM-5. And I just thought it would be helpful for us to go through a couple of things. So firstly, that OCD is now classified under obsessive compulsive and related disorders. So it was removed from the anxiety disorder category. The other thing is that the DSM-5 now allows diagnosis of OCD with individuals that might sort of lack the insight in terms of the irrationality of some of their behaviors. I think it's also helpful to add that there is a tic-related clinical specifier, and what that is that there's a distinct subtype of OCD, and in this particular subtype, compulsions often focus on symmetry, ordering, or kind of that just right feeling. So whilst kind of typical OCD is driven by anxiety-based obsessions, tic OCD is often kind of preceded by that sensory urge or physical tension. So just looking at a basic OCD cycle, this kind of includes the cardinal features of OCD, and people with different forms of OCD all tend to have the same cycle. That's whether it be contamination OCD or harm OCD. So it's reassuring to know that in initial assessments, OCD really sort of operates fundamentally in the same way. So just taking a quick look at, or a closer look into obsessions. So obsessions are recurrent and persistent. So obviously that they happen over and over again. They are intrusive and unwanted. So these thoughts are kind of occurring involuntarily and normally cause intense kind of distress, fear or anxiety. They are ego dystonic, and this is a really important point around within OCD. And that kind of means that the images or thoughts are inconsistent with that person's kind of true values and beliefs, and within their self-image as well. So the obsessions are basically opposite of what that person wants and believes. So an example might be sort of a gentle person experiencing sort of obsessions around violently harming other people, or you may get an individual that really loves their family, but they may experience kind of sexually violent thoughts towards a family member. So we need to just remember that these thoughts are against their true values and can really often lead to that individual kind of experiencing intense emotions, including shame, kind of guilt, disgust. So that individual also spend a lot of time sort of attempting to ignore, suppress, or neutralize those thoughts. Obviously, that's because they're very distressing. Um, and oftentimes these kind of attempts do fail and paradoxically can actually increase the obsessive ideation. This is called the thought suppression paradox. So I'm just going to introduce a small flow chart, and this looks at, I'm just going to introduce an obsession here. And normally people associate kind of obsession with contamination OCD. And what I'm going to do throughout this presentation is just going to try and introduce different forms of obsession so we begin to kind of get used to them. So what we've got here is a trigger, so the stimulus, and this can either be internal or external. So in this particular case, that individual's kind of feeling uneasy, things are not quite right. So this would be an internal trigger. That goes down to the obsession, and maybe something very generic, like something bad is going to happen, and then that causes the anxiety and distress. So just moving on to compulsions, and we will tie the two together. But compulsions are repetitive behaviors, and there are two distinct types of repetitive behaviors, one being sort of overt behaviors, such as hand washing or checking. And then you get covert behaviors, which are more those kind of mental rituals that other people aren't necessarily going to see. And that can be sort of praying or sort of counting in numbers in the mind. So there are also ritualistic compulsions, which are a sequence of compulsions performed in a routine or a particular type of order. And you commonly see kind of rituals happening, let's say, before bedtime. So these behaviors or compulsions are really aimed at preventing or reducing distress, or or in an attempt to kind of prevent a dreaded event or situation from occurring. The compulsions are not connected in a realistic way with what they are designed to neutralize or kind of prevent. And obviously they will also be very clearly obsessive, and I'll give an example shortly. Just to also say that DSM-5, there is a developmental specifier, and this is really a specifier for young children to acknowledge that they may not be able to articulate or understand the reasons why they're doing the compulsions. And having specific questions to help draw out that information and understanding is quite important. So just looking at the cycle over here, what we've got is a similar cycle to what I showed before. So the trigger is seeing a knife on the table, and we're going to relate this to harm OCD. So this obviously is an external trigger. The obsession is an image and an urge. So the image is stabbing his sister, urge is picking up the knife, and the associated emotions are shame, distress, and disgust. That then goes to the compulsion, and in this case, it's counting to 12 4 times over in the mind. So this would be a covert compulsion. You can see through here that this is quite excessive counting happening, but that compulsion kind of leads to a sense of temporary relief, and that forms the actual OCD cycle. So I'm just going to add over here what happens, obviously, when that compulsion is carried out, that person experiences temporary relief. That behavior now is negatively reinforced. So now this is where operant conditioning kind of occurs, whereby sort of removing that really uncomfortable feeling or distressed emotions creates a reward and therefore actually strengthens those behaviors. So the compulsions are strengthened. There's two important facts connected with this as well. One, that this reward actually reinforces the belief that the compulsions is what has prevented that bad thing from happening. This can be often referred to as magical thinking. And in this case, it's that belief that counting has prevented that harm coming to his sister. The second thing about the negative reinforcements is that even if that young person kind of recognizes that the actions are unconnected to neutralizing that feared event, they will often feel that they have to do this. And it may be due to this kind of sense of, I need to do this just in case, or what if this thing happened if I didn't do the compulsion? So that's very, very common as well. And it's just helpful to acknowledge at this point not to confuse this with GAD, so generalized anxiety disorder, where that young person is not able to tolerate uncertainty. So both of these conditions, GAD and OCD, both disorders do have high levels of uncertainty, but obviously they have different cycles and they manifest differently as well. So we're just going to have a look at some very common obsessions and the related compulsions. So contamination fears, which is one of the most common, and the associated compulsion may be excessive hand washing, fear of harming others, that would be checking and rechecking. Unwanted sexual thoughts, this may be associated with counting rituals. Fear of losing control, mental rituals, religious obsessions, maybe covert compulsions, for example, praying excessively, perfectionism, reorganizing, we see that quite commonly as well. Fear of making a mistake, seeking reassurance, health-related fears, frequent doctor's visits, for example, relationship doubts, repetitively asking for reassurance, violent or aggressive thoughts may lead to some sort of avoidant behaviors. I just want to tap into a couple of these areas over here, and I'm going to extend a little bit further into the sexual OCD. This can often be bypassed by clinicians and also that young person. And this is really due to the kind of taboo nature of those obsessions. And just to sort of bring some clarity here, that there is a misconception, or can be a misconception, around kind of sexual obsessions being fantasies. However, we need to kind of be mindful that fantasies and obsessions are very, very different in nature. So fantasies may be consciously chosen and kind of understood to provide some level of pleasure. But sexual obsessions are like any other obsessions in that they're unwanted, they are intrusive, and they're normally there, and that person will, obviously attempt to get rid of those thoughts kind of continuously. And that's almost always associated with feelings of guilt or with shame. And the same applies to sort of the harm or violent and aggressive obsessions. So whilst the images or urges are present, we obviously just need to be mindful of the ego-dystonic element of obsessional thoughts. And this is particularly important when we're kind of assessing risk. We just need to hold in mind that the obsessions do not reflect the intent or will of that individual. So just a quick acknowledgement around sort of covert compulsions. It's very unlikely that young person will voluntarily share their experiences of mental rituals or compulsions. And if parents are in that room within your IA, sort of supporting that young person, oftentimes the parents themselves are not aware that these covert compulsions may be occurring. So another point is that often the young person won't actually recognize these mental compulsions to be OCD compulsions. And kind of as mentioned earlier, I'll just run through some specific questions you can ask to try and sort of establish if these are present. So how to identify moderate to severe OCD at a glance? So what we're going to do here is just literally place this onto a spectrum. It's the easiest way to kind of do it. And the key features really are the daily time spent engaging in OCD behaviors, the level of distress, and the impact on daily functioning. So really what we're looking for is the level of impairment of the OCD. So in terms of mild OCD, we would typically be looking at infrequent symptoms of up to an hour. Generally speaking, the distress levels will be manageable, and generally speaking, that young person will be able to attend school, be functional sort of within the family environment, be able to socialize. When we kind of escalate that and we begin to go into sort of moderate OCD, the symptoms obviously will be more time consuming. They may take over an hour a day, and obviously that will cause kind of marked distress. That young person may be able to attend school, but there will be some levels of impairment, such as that person's ability to concentrate, and they may also avoid or kind of feel unable to socialize. Home life as well may be impacted. So severe OCD, we're looking at real near constant, very disabling and time-consuming symptoms. So we're really looking at 3 hours a day plus. Levels of distress would be incredibly high, really unmanageable for that individual. And overall, that person will be very significantly impaired. That young person may not be able to get into school or struggle to get into school. They would not be able to really effectively socialize. And in many cases, we see this very often. Oftentimes, they're actually homebound and haven't been able to get out at all. So when we kind of assessing for OCD, I'm just going to share some key kind of questions. So obviously, when you have an inkling, if there's an idea, okay, this could be OCD, what we're going to do is just introduce some OCD specific clinical prompting questions. And this is really helpful because often our young people lack that insight or a verbal ability to communicate their OCD experiences. We kind of touched on that a little bit earlier. We will often hear young people kind of describing this experience of needing to do something, and until it actually feels, it feels just right. But there again, this in itself is quite a big indicator of OCD. So I'll just share some examples now. So this is specifically when we're looking to identify obsessions. So do you have unwanted thoughts, images, or worries that keep coming into your head, even when you try to get rid of them? Also, just to say as well, obviously, you'd need to adapt these questions so that they just age appropriate for that young person. How much control do you have over these thoughts, and how hard is it to ignore them? Do you feel a need to carry out specific repetitive actions to reduce these difficult feelings caused by these thoughts? So over here, what we've got are sort of questions around compulsions. So do you do certain things over and over to help make the thoughts go away or feel better? It's helpful to give maybe some examples. So for example, counting or washing your hands. do you have to do things in a specific repetitive way or order? So, for example, in a special sequence before bed. Is it important that your parents and family are also involved in behaviors that help you feel that distress is kind of being reduced? I think it's really important as well, just at the bottom over here, it just says that we must validate and kind of recognize the emotions and, sort of can communicate this by just kind of, that must feel difficult. I can understand why you feel that way. And that's because OCD can be really difficult for a young person to talk about, in particular if the obsessions causes that young person a lot of shame or guilt. So do take a bit of time to kind of acknowledge the difficult feelings and both normalize and validate their experiences. So we're just going to look at differential diagnoses now. And the first one would be sort of autism. And we see this commonly sort of comorbidity, but also we need to kind of be able to understand the differences between ASC presentation and OCD presentation. So whilst both include kind of repetitive behaviors and strict routines, they differ in motivation. So OCD rituals are obviously driven by fear-based anxiety or to prevent a feared outcome from happening. So again, these are ego dystonic features. So the autistic routines or repetitive kind of stimming behaviors may provide comfort and sensory regulation, and these are ego systonic behaviors. So in terms of anxiety disorders, I'll just sort of focus in on GAD, which is generalized anxiety disorder. This often involves kind of worries about real life situations or events, whereas OCD normally involves sort of irrational and intrusive thoughts. Phobias are usually specific and kind of lack the complex rituals that OCD has. In the case of low mood, sort of the ruminations in sort of low mood and depression are typically mood congruent, whereas OCD thoughts are kind of intrusive and distressing. So some other thoughts, some other differences that are within the OCD is that the person often knows that the obsessions are irrational, but cannot stop them from happening. Whereas in terms of depression, these are normally sort of based around hopelessness or feelings of worthlessness. So in terms of body dysmorphic disorder, OCD and BDD are very closely related, but the primary difference would be the focus. So within BDD, this centers exclusively on kind of perceived or imagined flaws in that person's physical appearance, whereas OCD involves, a diverse kind of general obsessions, although they may be themed, as we introduced earlier. So tics and Tourette syndrome, so obviously these are neurobiological impulses, so they sensory urges that involve kind of those involuntary, repetitive movements or vocalizations, whereas OCD, as we know, is kind of very rooted within anxiety and cognitive obsessions. So it'd be just helpful to introduce also PANDAS. So PANDAS cause a sudden and dramatic onset of OCD symptoms and or tics in children, and this is usually following a kind of strep infection. So whilst these symptoms share, or whilst they look very similar, the PANDAS is an autoimmune response, whereas traditional sort of OCD is not. Okay, so we're gonna just move on to the treatment of OCD, and the recommended psychological treatment for OCD is CBT, including exposure response prevention. And this is for our 5 to 18-year-olds. And this is reflected within our OCD framework as the first line intervention. And this would be regarded as the kind of gold standard evidence-based treatment for OCD. We may also want to kind of consider whether psychiatry need to be involved, and this may be determined by sort of risk, complexity, the severity of the OCD, and really whether sort of pharmacological intervention might be helpful alongside ERP as a kind of combined approach. So for the under fives, the recommendation would be getting help services, just depending on that young person's needs. Sometimes that young person may not be able to access ERP, and this really can be down to a variety of reasons. So the process that would be followed in terms of this is that following a therapy formulation and hopefully agreed within an MDT, an alternate treatment can be kind of recommended. And on our framework, this would be sort of a systemic intervention or the SPACE program, SPACE kind of standing for supportive parenting for anxious childhood emotions. So just to briefly cover SPACE, because I know this has been sort of newly introduced, it's a parent-based program and it's manualized. And this is to treat children or to support parents to support children struggling with anxiety disorders and OCD. It's currently used within our national and specialist teams, so SLAM, our OCD and BDD clinics. And essentially, SPACE is a program that sort of provides an intervention for parents in helping to reduce kind of family accommodation. It also allows the practitioner to support that family with specific strategies, and that will be based very much so on that particular young person and their family. So we're just going to have a quick look at the steps of ERP, and this may be helpful if you ask questions around this in your in the initial assessment. So that practitioner will take through that person, sort of just helping them increase their knowledge around ERP. And it just also provides a clear rationale for ERP. And it's particularly important as that young person actually voluntarily needs to experience some level of anxiety. And so understanding what ERP means and these levels are going to be experienced just helps build a little bit of motivation and some comfortability when they're presented with quite challenging and often uncomfortable exposure challenges. They would build a hierarchy to identify those fears and compulsions. They would then carry out the exposure and resist the compulsions and sit with the discomfort. And this is the response prevention side. And kind of repeat this procedure until those distressing emotions kind of subside. Just a quick thought around inhibitory learning. So historically, sort of ERP and exposure therapy was based on the thought that this was down to habituation. But the new and sort of modern evidence-based approach kind of focuses more on creating sort of safety memories. And so instead of kind of passively waiting for that anxiety to subside, inhibitory learning-based ERP kind of acknowledges that initial fear may remain, but you would actively kind of build on sort of new memories that help inhibit that original fear. And it also helps with increasing the tolerance of kind of that uncertainty. And then obviously we would review and check that young person's progress throughout. So that's really the end of the whistle-stop tour of OCD. And I do hope this has helped build some further understanding. Please do reach out to me if you have any queries around OCD. I'm normally sort of kicking around somewhere. And yeah, wishing you all the best.